My name is Katie Loomis, and I'm a first-year PhD student in the Chan Division of Occupational Science and Occupational Therapy. My presentation is on therapist-patient relationships in hand therapy, which is based on 2016 data collected by Dr. Hardison. I coded and analyzed the data myself, and I consulted with him along the way, and I also consulted with Dr. Roll on the organization of this slide. So traditional hand therapy is rooted more in a biomechanical approach. However, there has been recent calls for more holistic and collaborative treatment planning and patient care, which requires a shift from compliance to adherence, or basically that means that the patient has to be more of an active participant in the process. So fully embracing this shift requires us to re-examine the therapist-patient relationship and the dynamics within it. So the purpose of this study is to explore perspectives of hand therapists to identify factors within this relationship that impact the provision of holistic and collaborative services. I used principles of grounded theory to analyze the data, which was 13 semi-structured group interviews of 4 occupational therapists, 2 of which were more experienced therapists and 2 of which were OTD residents. So 4 main themes emerged surrounding this relationship. On the top left, we have power dynamics, which were power was fluid between the therapist and patient and the greater healthcare system. So that meant the doctors or insurance companies. And when there was disagreement, often the therapist had to mediate between the 2 parties. So we have a quote here. The doctor told her she won't be able to box again, and her goal is to get back to boxing anyway. So I went to the doctor and said, she wants to box. And he looked at me and he said, she cannot box. There's going to be a disconnect. I have her shadow boxing. I have her do mirror therapy. So the therapist is trying to find a middle ground here. On the top right, we have emotional states, which were dynamic for both patients and therapists and could vary from session to session or even within sessions. Therapists dealt with these emotions through different strategies, first of which was venting, which meant that patients were allowed to express and kind of release negative emotions to feel a sense of relief. And we have a quote associated with this one. The fear and anxiety, a lot of it was just through talking with her. It was just socializing with her and letting her explain, kind of venting her. So second was reframing, where the therapist would talk with the patient about where they currently were and how far they had come since they had started therapy. And lastly, humor, or just trying to lighten the mood through jokes and a silly kind of environment. And we have a quote for this one too. We make everything more lighthearted. It takes maybe the seriousness or the heaviness of injury kind of out of the way. And then on the bottom left, we have engagement, which was co-constructed between therapist and patient rather than being something just isolated to the patient. The therapist's participation in this process involves caring, showing that they cared to the patients, and then adaptability to changing circumstances or problems that arose or different needs of the patient. For the patient, this meant motivation to move beyond their current state and buying into the fact that therapy would help them get there. And we have a quote here from an OTD resident. The experienced therapist had more time to learn how to adapt. Sometimes a patient expresses frustration, or the patient might even disagree with something the therapist does, putting the therapist in awkward positions, how to roll with the punches, so to speak. And lastly, different kind of temporal and spatial realms that dictated the roles of the patient-therapist relationship and also kind of mediated the other factors surrounding it. So first, social versus private. Social was more camaraderie with other patients. They were being treated in the same room and they were comparing their experiences, versus private was more of a safe environment where patients could vent and talk about sensitive topics. Next, clinic versus home. Clinic was more of a collaborative effort between patient and therapist, versus home, the patient had more responsibility for their own care. And lastly, during therapy versus after discharge. During therapy, the patient and therapist had a very close, intimate relationship that abruptly ended upon discharge, and then the patient was the only person responsible anymore. And therapists found that this was difficult to get patients to be ready for this process of discharge and kind of being left alone. So we have 2 quotes here. He used to come in and just burst out crying, and I'd have to put him in a private area, and I was really glad he felt safe. And second, there are some people who, when we have to discharge them, they say, no, I want to keep coming. So what does this all mean? Basically, the therapist-patient relationship is complex, intimate, and dynamic. It extends beyond patient education and application of physical interventions. Therapists highlighted the importance of all these different factors surrounding this relationship and treatment, but they had difficulty communicating the specifics and quantifying progress associated with them. So further investigation may help promote collaborative care by foregrounding these interpersonal and psychosocial aspects for assessment and treatment purposes. Thank you for your time.